So I think for last 2 lectures we have been continuously hearing about continuous glucose monitoring. But what I am going to do is I am going to take you to the clinic as to how actually we are doing with the technology that is available to you. It is going to be totally case-based learning. So I'm going to share with you cases, but in a flow-wise manner. So disclaimer is that I called up all the continuous glucose monitor providers in last 1 week to ask what is exactly they are providing us, because most of the times the MRPs which are there on these monitors and the actual price that they are available might be different. So I called up all of them, especially for the cost respect, but none of them have funded or supported this talk. So this talk is not for any continuous glucose monitoring system. What I expect at the end of the talk is to tell you how CGM is the biggest game changer in diabetes in recent time. In fact, I would call it as an anti-diabetes therapy which does not require cardiovascular outcome trial. I'll show you cases in which just using continuous glucose monitoring has either brought down the HbA1c without changing the medications or reduced the medications to maintain the same HbA1c level. And that is what I would call as anti-diabetes therapy. Second is what options are available in India, how much they cost and how to actually use them. And then cases to tell you how and where we can use the data, which is a lot of data, to the maximum use and the minimum headache, right? So the biggest game changer, options available, cost, use, and then cases. So continuous why are we calling this a biggest game changer? Because I know we are looking at it as technology which is costly, for which we need to pay, but looking at the effect that it has on not only medication improvement but also behavioral improvement, I would call CGM as one of the strongest anti-diabetes therapy, as good as another molecule being discovered to manage diabetes. So there is a total whole recommendation by a consensus, and you have heard two stalwarts who have been part of the consensus, Dr. Fonseca and Dr. Grunberger. Yesterday you heard from them. And like I said, it has been shown to improve the HbA1c. So finished with that. Now we have what are the options available. So currently, as of 2019, this month, we have these options available to use the continuous glucose monitoring. This is the Medtronic Guardian Connect, which has a sensor, a transmitter, and it can get attached to your phone. This costs 2,000 rupees, 2,300 per sensor, which lasts for 1 week, and you need to buy the transmitter, which is 49K. This is the patient's kit. Then we have Medtronic Guardian Connect 2, which is just a professional sensor. It doesn't give the transmission to the patient, no real-time data. Then we have Dexcom, which also has a real-time data. The transmitter, the reader is 1.5 lakhs, and each sensor costs somewhere around 10,000, which works for 1 week. Then Medtronic iPro 2, 2,300, only a sensor. Sorry, Guardian 2 Link is the one which gets attached to the pump, the sensor augmented pump. And Medtronic iPro 2 is an individual sensor which works for 1 week, and it is a blinded or a professional sensor. And then this is, I think, the most revolutionized thing which we had, which is a Liberapros from Abbott. In India, the only professional version is available, where the patient buys the sensor and the doctor needs to buy the reader. So the patient doesn't have access to his data. He has to come to the doctor to look at the data. But he can buy the sensor from the pharmacy, we can attach it, and the patient can come to us for the reader. In Western countries, the reader is also available to the patient. I am sure in no time it will come to India also. But right now, the patient doesn't have reader for the Abbott's Liberapro. All these work for 7 days. This works for 14 days. These are real time. They immediately give you what is the result. These are professionals because the patient has to come after a week or 14 days to you to get the data. Now coming to the original presentation, that is case-based learning. So there are 4 reasons why we do continuous glucose monitoring, and each I'll discuss with the case. One is diagnostic, then is interventional, then is clinical outcome, and then reference. We may not have a different case for each of them. You can use all 4 parameters in the same patient. So let's look at the diagnostic thing. Case 1, diagnostic to understand the exposure and variability. Intervention, most of my experience in using CGM is that we actually need to descale the medications. Most of the patients who are using CGM are actually landing up in reducing the oral anti-diabetes medicine, and in spite of that they are having better HbA1c control. I may be wrong, my experience may be biased, but this is what I have experienced. Clinical outcome increases patients' trust on you. We'll discuss that during the case. So case 1, this is a real patient, a 67-year-old lady. I want you to look at her HbA1c, which is 8.1, and I want you to look at her medications. I am not sure you're able to read it. I'll read it for you. Riomet 1, Glycomet GP 0.51, Pioglitazone and Metformin 1, and then some multivitamins. So we did her Abbott Libre Pro sensor. I asked her to come back. These are her reports, right? What do you have when you look at these reports? A headache. What do I do with this graph? And that is what we are going to discuss. Now, if you look at these 4 graphs, all of them have HbA1c somewhere around 6 to 7. And if you look at these lines, you can see that they are nowhere similar to each other, right? So what are we going to talk about are 4 parameters to look for in this graph: variability, stability, exposure, and risk of hypoglycemia, right? What is exposure? Is the area under curve of the hyperglycemia. That is equivalent to HbA1c. So how long this person had been exposed to a high glycemic status. Second is variability. Variability is the difference between this dark graph. This is called interquartile range. That means 75% above, 25% percentile below. So this is the time that 50% of the time of the day the patient's reading had been in this portion, right? If this is narrow, it means the variability is less. If this is wide, that means the variability is high. Now you need to only see whether variability is low or high. You don't have to look at every point blood glucose and then try to see yahan zyada tha, yahan kam tha. Just remember, when we have to monitor variability, it can be low, it can be high. If the graph is narrow, it is low. If the graph is wide, it is high. Then stability means blood glucose at the different time of the day. We make 8 hours section. Morning it was low, afternoon it was high, again evening it was low. So this is stability. Third, for exposure, variability, stability, and fourth is risk of hypoglycemia. So this is risk of hyperglycemia, the upper graph, this one, and this is the risk of hypoglycemia. Now what we do is, we scale them. I am not going to go into detail, but we scale them on the basis of variability, stability, in hypoglycemia risk, variability in 50 percentile, variability 90 percentile, and then we make a report of it. We can discuss this in detail in a workshop, but right now we need to understand that we need to systematically put them as 1 plus 2 plus 3 plus 4 plus on these 4 accounts. And then what we do? 8 hours section of the day for 24 hours. So looking at this patient's graph, the patient's real graph, okay, can you see that the variability is not much? Because the dark graph is very narrow, but the interdocile variability is high because the light graph is very wide. This is one diagnosis. This is the diagnostic advantage of using the continuous glucose monitor, that I diagnosed that 50% of the times her readings are within normal, but when I go to 90% it is going up and down, and you can see the stability. It is high only at that point. It is not high here, it is not high here, it is high here and it is high here. So these are only 2 points of the day that I understood that the blood glucose is going up, right? We can look at that with the everyday graphing also. This is an everyday graphing. This is the monitor, the report itself is giving you what is the probability of low and high. And this is per day graph, right? Which is the most commonly used graph in the CGM report. We do not look at these 3-4 pages which are there in the beginning, and we only look at the last page. So no headache, right? Simplify it by categorizing it in 4 parameters, graph it properly. So this is diagnostic. Now let's look what is the intervention we are going to do. Okay, I diagnose the variability is small, the interdocile variability high. So what? So what's the next step? Look at her prescription. She was on glimepiride, metformin, pioglitazone, metformin, right? We stopped her pioglitazone, put her only on one metformin gliptin combination and small dose of sulfonylurea. Then what did intervention? This is her intervention graph. Okay? What we need to see here, the most important use of CGM is to identify hypoglycemia. This is the first thing, because if you look at this high level, it is always preceded by a low. And this is the most common thing that happens when patients are over-medicated. They have hypoglycemia and the counter-regulation will cause hyperglycemia, either overeating or hormonal counter-regulation. So if we take care of this, the hypo part, the hyper part automatically comes down. Can you believe the HbA1c of this was 8.1 with so much of hypoglycemia and so much of anti-diabetes medicine? And with just 2 tablets, this is what she has gone, still getting some hypo. So I stopped her sulfonylurea also. And the person whose HbA1c was 8.1 with pioglitazone, sulfonylurea and metformin is just combined with DPP-4 inhibitor and metformin, and her HbA1c is controlled. And she doesn't have hypoglycemia. That is what CGM can do. And then comes the, after the intervention, clinical outcome means what? That we document. It's important today that we document and show the clinical outcome to the patient and not just to satisfy our judgment. For example, if she would have come to me with 8.1 HbA1c with 3 medications, and if I would have stopped her medication without showing her this, she wouldn't have any trust on me. But now I can show her why my clinical judgment is justified. And that is what is called as clinical outcome. It is not only important for you to see it, it is also important for the patient that he trusts on our judgment. That is nowadays a very important thing, because patients are no more blindly trusting the doctors. Another case number 2, these are going to be short cases. A gentleman who is 67 years old, had some pacemaker surgery and all that. His ejection fraction is 10%. And he is taking pre-mixed insulin 16 in the morning, 14 in the evening, because none of the other medications are safe when your ejection fraction is 10. He is frail, is getting admitted every 15 days in the hospital. I don't think he has much lifespan. And HbA1c is well controlled, 7.2, so everything is continued. Graph is also very good. But he says that is everything all right? I just came for a second opinion. I said, let's see, your quality of life is getting poorer with pre-mixed insulin twice a day. You have to continuously eat to keep the blood glucose into the normal ranges. He is now controlled only with empagliflozin 5 mg. I would agree with you if you argue with me that is it safe to give empagliflozin? He doesn't have much lifespan left. I just want him to have a comfortable life. 1 tablet and his HbA1c is absolutely controlled, fine for me, I guess. Meal management and changes in oral diabetes medicine. This is a patient who is coming with this. So lifestyle changes are also very well managed when you show the patient what is happening. What is happening to me when I eat idli versus what is happening to me when I eat egg. So on one day breakfast, if you take idli, what happens? On the other day when you eat egg, what happens? When you show it to the patient, it has a great impact. Why I want you to look at this graph is because it works for 14 days and all of us are tempted to use first 1 week for diagnosis and second week for looking at intervention and clinical judgment. Mind well that The oral anti-diabetes medication change will take time to show. So the next weeks for 3-4 days may not be a real representation of the changes made by you in the medications. So you might have to use 2 sensors in continuation to see the real change. So we saw diagnostic, we saw interventional. Let's see the reference. What does reference means? So an elderly gentleman on metformin DPP-4 combination or whatever medication he is taking, HbA1c is 6.4. When HbA1c is so tightly controlled and my patient is affording a CGM, I would like to see, just put on CGM and see that just everything is okay. Fine, everything is okay, HbA1c is controlled, you don't have variability, you don't have instability, there is no risk for hyperglycemia, there is no risk for hypoglycemia, you are good to go. You can go to America, you can go to Ladakh, you can go for trekking, you can go for scuba, you can go for swimming. So that is kind of a comfort zone that I have now over and above the HbA1c, that everything is okay, you are good to go. Real-time continuous glucose monitoring is totally separate from the professional glucose monitoring that we are doing. Now I have 2-3 patients who are on real-time glucose monitoring. I prefer not to use the continuous real-time glucose monitoring unless the patient is either on multi-dose insulin therapy, that is basal bolus, or insulin pump. Insulin pump would be the most preferred indication to use a continuous real-time glucose monitoring. Because what do you do with the minute-to-minute input from the continuous glucose monitor, real-time glucose monitor? Unless you are continuously changing the intervention, there is no point in continuously getting an alert, your blood sugar is 100, your blood sugar is 200, your blood sugar is 350. So it is very important, only important during the pump. And as Dr. Rakesh Sahai sir also said, my patient who was using pump had better control when I put him on sensor augmented pump, that is real-time monitoring plus pump, but he has stopped using the sensor because it is giving him continuous alarms and he is irritated with it. He is also a doctor. But he is only using pump now. He has bought the sensor augmented 640G along with the pump. He invested in it, but now he is using that pump just as a normal pump Minimed and not using the sensor. So you have to be very careful before asking the patient to invest 4 to 5 lakh rupees in that sensor augmented pump, that the patient is really motivated and psychologically ready for using that sensor augmented pump and continuous real-time feed of your blood glucose. I do also have a patient who owns a helicopter who wants a continuous feed of his glucose levels. So okay, if you have someone like that, you can give it. So to summarize, continuous glucose monitoring is one of the anti-diabetes medication that has come to improve HbA1c. We have very good options in India. We don't have to think that we don't have options in India. The report should not become a headache if you systematically put it into variability, stability, exposure, and risk of hypoglycemia. Risk of hypoglycemia is the most important and first one to look for. And real-time continuous glucose monitoring is useful only in selected patients. Otherwise, most of your cases can be handled very well with professional continuous glucose monitors. So that's all from my side.